فري قولوا لي كده يبقى
الهاند فري تبقى كويس. انا هعمل بس مقدمه، هنرحب بالناس بالعربي انا خلاص، ونقول لهم احنا بنعمل ايه، وبعد كده حضرتك هتقدم دكتور رجيش، هتقدم نفسك طبعا وهتقدم دكتور رجيش، ونبتدي على بركه ان شاء الله في ميعاد الساعه.
الصوت كده واضح؟
واضح يا دكتور، واحنا جاهزين ولايف على الفيسبوك كمان.
كده اوضح؟
واضح.
هاند فري؟
كده لايف فيسبوك يا امير؟ طب تمام.
اوكي. Hi Dr. Rajesh. You are much welcome to our Egyptian activities. It's a very famous initiative here in Egypt, and all of us are glad to meet you, to welcome you in our group. You are meeting now Dr. Baha and Dr. Amir. They are the main coordinators. We can say they are the generators of the pediatric learning in Egypt, and their effort is equal to 4 or 5 universities together.
Yes.
Dr. Baha, Dr. Amir, Dr. Rajesh, not only my head of department, he is my elder brother, and he is very interested in teaching, learning, besides his PICU expertise. There is a very famous course presented by the European Society of Pediatric and Neonatal Intensive Care. It's called the basic course, done in many countries. Dr. Rajesh was one of the main coordinators of that course. So I hope all of us work with him either in person as me or to learn from his expertise, and as he will tell us tonight.
بسم الله الرحمن الرحيم. طيب هنبتدي يا شباب. امير اوكي نبتدي كده، احنا لايف صح؟
لايف يا باشا، اتفضل.
بسم الله الرحمن الرحيم، والصلاه والسلام على اشرف خلق الله سيدنا محمد وعلى اله وصحبه ومن والاه. اهلا بحضراتكم في اولى ليالي الخبراء. احنا بنحاول ننقل الخبرات من كل دول العالم، فاحنا حاولنا هنبتدي من الدول الاجنبيه ومعانا الدول العربيه من بكره ان شاء الله. كل يوم معانا من دوله في تخصصات طب الاطفال المختلفه. بنحاول ننقل الخبرات دي. فاحنا دكتور احمد عطيه غني عن التعريف، حضراتكم عارفينه، استشاري طب الاطفال وعنايه الاطفال. تواصلنا معاه وتواصل مع دكتور رجيش، فهيكون معانا دكتور احمد هيقدم دكتور رجيش، ونبتدي المحاضره الويبينار ان شاء الله. انا متشكر لحضوركم ومتشكر لتعبكم، وان شاء الله تستفيدوا ونستفيد جميعا باذن الله. اتفضل دكتور احمد بيه.
السلام عليكم، كل عام وانتم بخير. سعيد جدا اكون معاكم النهارده. هو بسبب ان محاضره دكتور رجيش، فابتداء من الان هضطر هبقى كله بالانجليزي. انا عارف انه بفضل عندنا فرانكو عربي، يعني هو اطباء مصريين، بس طبعا عشان الدكتور رجيش ضيفنا لازم يكون عارف هنقول ايه بالظبط. So good evening, my colleagues and friends. I am very honored to be with you tonight. I'm just the host. Our lecturer is Dr. Rajesh. He is going to discuss some cases today with errors. Learning from errors is as important as learning from doing the right thing. Sometimes it may be even, it's better to avoid errors better than doing the right thing. You know, first do no harm is the first and the most important principle of medicine. Tonight, I'm very glad to present one of very skillful pediatric intensivist I have ever worked with, Dr. Rajesh Phatak. He is not only my head of department currently, but he is also an elder brother and a dear friend. He works currently as head of department of pediatric intensive care unit in Burjeel Hospital, Abu Dhabi, UAE. But he has a very intriguing working portfolio. He worked previously as a consultant in pediatric intensive care in Royal University Children's Hospital of Manchester, in the Alder Hey Hospital, Liverpool. He is also clinical lead of the Northwest Pediatric Critical Care Network. He is a co-lead of Northwest and Wales North Wales Pediatric Transport Service. He is exam board member of Royal College of Pediatrics and Childhood and Child Health. Many work experience, very rare to be available for one person, but actually it happens with Dr. Rajesh. So welcome with me with Dr. Rajesh. Rajesh, you can start.
Thank you so much. Can you see my screen?
Yes, Dr. Rajesh. Yes, presentation is.
Okay,
I can see you.
excellent.
Yes.
Excellent. Can you hear me as well? That's great. Okay. I have headphones, but I'm not putting them on at the minute. But if you feel that will help, I'm very happy to switch to headphones. At any point, if you feel you cannot hear, I am very happy to switch to headphones. So it's a big honor and pleasure for me actually to do this session. It's a bit of unknown, so bear with me. I didn't know what I wanted to include in the session, so I have gone on to include a few cases. And I think what I'm really looking to do is to share my experience in the last maybe 10, 15 years and maybe learn something from you as well. So I suspect and I believe that many people who are attending online are actually working in Egypt. That's a place I wish to travel to. I've never been to Egypt, but currently for the last 4 or 5 years, I've been working with a very, very dedicated team of clinicians, many of whom are from Egypt. So I think I owe a debt of thanks to the land. So hence, I feel able to contribute to this session. And many thanks for having me on. So as we all know, intensive care and particularly pediatric ICU is a very high risk, high stakes specialty. And the rewards are also equally good if we are willing to put in the effort. So why I say high risk? Because things can happen within seconds and minutes, and most of them are unintentional. There are very, very few, they're not zero. The number of intentional errors or criminality creeps into ICU. There are isolated events, but I'm not going to discuss criminal behavior within the confines of ICU. But what do we see here in these two radiographs? So one on the right shows ET tube in the right main bronchus. So this happens very, very easily. You have a sick child, we are intubating them, the child desats, we put a tube down, and lo and behold, the child desats even further. And I think it's very crucial to bear your thoughts at this point in time, take a pause and ensure how far the ET tube has gone in. And it takes presence of mind to withdraw ET tube to the correct length. And this happens much more frequently in small babies and children compared to older people. So for older people, box standard, they'll intubate 40-year-old person, 50, 60-year-old person. They're not going to really change the depth at which you fix the ET tube. Even they tie. I don't know what you use to fix your ET tubes, but in many places where I worked, we use a version of sticking plaster or elastoplast to secure the tubes. So that's one take-home message. And always use capnography to ensure your ET tube is in the trachea, because there is no other foolproof method to legally document that your ET tube is in the trachea. So the other X-ray shows a nasogastric feeding tube going down into the right main bronchus, indeed into the right lower lobe. And thankfully, nobody started feeds on this patient. Can this happen? Yes, it can happen. There are instances of kids having had this, and certainly patients have died of this. So very simple intervention, putting a NG tube down through the nose or the mouth and checking it is in the stomach. So getting gastric aspirate and checking the pH is a much more reliable indicator than insufflating the tube with air. And many places continue to do that. And I really want to discourage clinicians from insufflating air to check the tube position, because the noise we hear with a stethoscope is almost exactly the same, whether it's in the lungs or in the stomach. So use a pH paper, and if nothing comes back, please use an X-ray to ensure the tube is in the correct place. So just a little tester. So you all have smartphones or laptops or something. So put this into your phone, go to this website, slido.com, and put in this number 2764832. And let me know when you've done that. So it's a very simple questionnaire that I am seeking to get your response to. Oops, I don't know where it's gone. It's a bit of a nightmare. Okay. Yep. Can you do that for me? Hello? Is this working?
Yes, working with me, Dr. Rajesh.
Okay. So please put in your response on the poll. Is this what you see, or a variant thereof? Oh, yes. Okay. Wow. Okay. So I can see 3 people have voted so far and some more. Okay. It's not really a test. You can choose whichever you like. There's no way anybody is going to confirm. So this is to achieve 2 things. One, to make sure it works, and number 2, to make sure you're awake and participating in this activity. Okay, there's a fair few who have participated. Okay. So I'll go back to my slides, I think, and you can continue to put in your votes over the next 5 to 10 minutes. Okay. So this is the number and a website for those who still want to do it. Okay, so I'm going to share a patient story, one of 3 or 4 patient stories that I want to discuss, and maybe there are some take-home learning messages for all of us. And I'm trying to look at the wider theme or the wider message, not a particular patient, but here we go. So we have a referral for a 12-year-old lady, a girl, who is 55 kilos, who came to the ER with a 4-day history of vomiting and chest pain. She has some degree of breathlessness, and she arrives with a tachycardia or a tachyarrhythmia with a heart rate of 150, 160. And lo and behold, the clinician there feels she has a SVT. So they call the pediatric team as well, definitely for a patient under 16 or 18, as in many areas, in many health sectors, I think you would call a pediatric team. And so what are your thoughts at this stage? I mean, for me, a 12-year-old with a SVT is a very uncommon scenario. I initially thought this might be a 12-day-old. Well, no, it wasn't. It might be a 12-month-old, far more common to have tachyarrhythmias or a tachycardia, but no, it was a 12-year-old patient. And that became clear to me when they said the patient is 55 kilos. Okay. So they put in 2 big cannulas, they gave some adenosine, thinking this was a SVT. It absolutely had no effect. So they proceeded to pursue a venous gas, which I think is a very, very useful thing to do for all sick patients. And if possible, if facilities exist, I would definitely encourage you and your clinical team. And this is something we've embedded in our hospital as well. Our ER team nurses are very good at documenting venous gas. So she now has a heart rate which is slightly lower. The chest pain is better. with a little bit of morphine. The chest pain must have been severe for them to think of IV morphine as a potential medication. And what are your thoughts? What would you do next at this stage? So they do a ECG. The ECG, I'm sure, which is what many of you would have wanted to do, and a X-ray as well. The X-ray is unremarkable. The ECG shows ST elevation in these two leads. Unfortunately, I don't have the ECG to share with you, but I think she's come to a hospital where the local cardiology team get involved, and enthusiastic registrar does an echo and documents there is impaired function and dyskinetic septum. This is all events from the UK. So some practice variations will definitely be noticeable compared to perhaps the geographic part of the world where you're working, where I'm working currently. And but their thought process was aligned to the fact that they are thinking on the lines of, this is an anterior valve myocardial infarct with the chest pain getting better with morphine. She's a little bit better, but they really think she needs an urgent coronary intervention. So I'm going to ask you to go back to Slido and see if we can, look at the other question set and see what okay, so what do you feel is the diagnosis here, or what do you feel is the pathology given the story that we just heard? Is it any of these? So is it really an MI? Is it something else? And if you can see it, please put in your vote. I have voted, and I think some other people have also put in a vote, and very reassuring to see what people have put in. And you can continue to do this over the next few minutes. So you can put in your the annoying thing with this presentation or the Zoom is I can't see myself. I can't see the screen and the slides, but I have very little feedback from whether you can continue to see me or my audio is still audible. I'm assuming that this is all going fine unless I hear something from one of you. There are some messages in the background, but I can't get to see them at this minute. So that will have to wait for a little bit longer. So I'm going to ask you,
Dr. Rajesh, it's okay. You can continue. I am monitoring the situation. If any modification, I will tell you. Don't worry.
Sure.
Just continue as everything is working well, unless I will mute you at certain.
Sure. Okay. So
just for our colleagues, you just this slido.com, slido.com, and enter that number. It's code and keep phone on this screen. It will change automatically for the next question. Just it. Okay.
And don't worry, I'm not going to ask too many questions. This is something new I have tried, so I'm not entirely sure how well it would work within the setting. It works well in a room or etc. But when using Zoom or a distance platform, I wasn't entirely sure what the utility would be, but I've given it a try anyway. And thanks to everyone who's participating. So so far we got a 12-year-old young person who comes in with chest pain, and many people around her in that room are thinking she's probably got myocardial infarct and they want to do a coronary intervention, but they don't do this mainly because there is no pediatric cardiology department in that hospital. So they want her to go somewhere there to a hospital, to a children's hospital, or a hospital where there is a pediatric cardiology department. Okay, so the next question that naturally comes around in some places is not so much how she should go, but also how should she be transferred. I mean, she's otherwise okay. She reaches PICU in the Children's Hospital. She's jointly reviewed by pediatric and adult cardiology teams. There is a lot of discussion and debate. And eventually, there are reams and reams of ECG, and they're no wiser after the discussion as to what pathology really this is most likely to be. She eventually goes to cath lab, and I think she gets a sedation with propofol and very promptly arrests. But they manage to get her back. They do a coronary angiography, and lo and behold, there is actually no coronary pathology found. And then she comes back to ICU. She has recurrent VFRS on ICU, and a few hours later, she dies on ICU. Now, I think many of us were bewildered by the fact that we had unwittingly become participant to this story. But if you take a step back and think, many of you have identified the most likely pathology for this patient is likely to be acute myocarditis. And certainly a 12-year-old having a myocardial infarction is extremely rare. So on that day, I asked this question around my colleagues, and there was about 120 years worth of pediatric ICU expertise available in that room, and nobody had seen a 12-year-old with a myocardial infarction. That makes it extremely unlikely that this patient will have one. Yes, there are myocardial infarctions in infants if they have anomalous coronary arteries from the pulmonary artery, etc., etc. But those have a very different presentation to this young adult. And I think once a label sticks to a patient, it is very difficult to detach that diagnostic label and start thinking from baseline, from a history perspective. If people had said to us, okay, we've got a patient with possibly acute myocarditis, the last thing anybody would have wanted to do is take her to cath lab to see if her coronary, if she needs a coronary angioplasty. That almost certainly would not have happened. Whether an outcome would have been different, we don't know. We know acute myocarditis itself can be a fulminant disease, can be a fatal disease. Up to 20% of patients die with acute myocarditis. But there is a significant possibility that she could have survived. We don't know. So I think one of the take-home messages from this particular episode for many clinicians at a children's hospital, including myself, was to go back to the initial story and review things as they are. And common things tend to happen commonly. And those are the things that we need to think about first. Okay, not that the cardiologist didn't know how to diagnose myocarditis or cardiomyopathy. Of course, they knew. They do this every day in their job. But having a joint review with the adult and cardiology teams, which should be a strength in itself, didn't work out well for this patient. So I think the take-home message really is to maintain, try to maintain a clear perspective of the data available to us. And more, I think we're going to see the AI applied into clinical medicine. And almost certainly, I think if you ask any AI algorithm with this data, they're going to say, this is a tiger, it looks like a tiger. Okay, but if you throw in the context and realize this is actually a shadow, then and look at closely. So AI will never say 100%, it will say 98, 99%. So be careful of the context and make interpretations of the data available to you. Sometimes you have to take a step back to see the bigger picture. So now that was quite a dramatic story, but most days we don't experience, thankfully, anything as dramatic as that. So I want to focus our thoughts and minds on probably the far most common interventions or medications for children admitted to hospital. Nothing to do with ICU here. Most children who come to a hospital don't really come to ICU, thankfully. But many children who come will experience a combination of these. Okay, so they'll get oxygen therapy, they'll get fluids, mostly IV fluids, perhaps salbutamol, either as nebulization or IV. And some children invariably will get antibiotics. And I think if they are admitted to a pediatric ICU, the same interventions carry on, except we occasionally use diuretics and also use vasoactive medications. But perhaps the most significant intervention that we do in our clinical practice is reassurance. Okay, so we reassure, and just taking history is a part of that reassurance. So if you have, I think there are more problem families or more problem patients in situations where there isn't enough interaction with the clinician and the parent, because the parent is a surrogate for the patient. Most of our patients, or many of our patients, actually cannot have a conversation with us. So all the history taking, all the symptomatology, all the reassurance is via the parents. And if our team can reassure the parents, it leads to a much calmer experience for the patient and also for the parents. In a sense, we are looking after not only the patient, but almost always, we are looking after the family, isn't it? And I think once we put ourselves in the parent's shoes, we can start to realize what they might be going through, particularly if they're not a clinician. If they're a clinician, of course, they may have some understanding of what the pathology is, but even then, they may not have any insight into the management of what's going on. I clearly remember consultant anesthetist, both were anesthetists, and their kid had bronchiolitis, a very common illness, which I'm sure all of you will have seen and treated in your practice. But the kid deteriorated to a point where they needed intubation, and it was very difficult, or rather challenging, to manage. Both parents were anesthetists, mainly because they were of the view that we needed to ventilate the patient to an extent where the CO2 was normal. And it took us some time to convey to them that actually it's okay. It doesn't matter if the CO2 is 45, 50, or even 60 for a brief period, as far as the saturation is okay. And we got the tube in the right place, lungs look okay. And of course, the kid settled and got better and went home. But I think reassurance via information and education really plays a big role in what we do in our practice. So coming back to
Dr. Rajesh, sorry, can you drag that tool bar?
Okay.
It comes in the middle. Okay, thank you.
So, looking at oxygen therapy, so what oxygen saturation should we target, and why should we target a particular oxygen target? I wish I had used the Slido poll for this, because I really wanted to get a feel for what people thoughts are on this particular topic. But I unfortunately, I don't have a Slido tool. But it's important to appreciate why I think I'm trying to move this, but anyway, why we think of oxygen content. I mean, providing oxygen to tissues is one of our main jobs. I think we do probably only 2 jobs or 3 jobs. One is reassure parents, provide oxygen to tissues, and third is we provide pain relief to patients when they need it. So if we provide oxygen to tissues, we have to have some understanding, and I'm sure all of you who have been we've all been students of physiology, we understand this fairly well, where oxygen delivery is really dependent on the arterial content, oxygen content, and also the cardiac output. So if you think of oxygen delivery as going through a train, and the 2 main variables we can control to some extent are how much oxygen we deliver, so how much oxygen there is and how much of it is saturated, and hence the saturation of oxygen, that is the same number we see on the monitor. That's very important. It's far more important than the PaO2 that we measure on the blood gas. Okay, so it's much more important to have good hemoglobin, as in a good value of hemoglobin. And there are many studies who looked at low transfusion thresholds versus high transfusion thresholds. after cardiac surgery or after non-cardiac surgery. I think the important aspect there to remember or to understand is that all these are applicable in stable patients. Okay, so these are not applicable, all these thresholds are not really applicable in sick patients, certainly not in septic patients. So if you have a septic patient whose hemoglobin is maybe 7 or 8 and you're debating, are we providing enough oxygen to tissues, then perhaps that is not the papers you want to look at. And I think this is self-explanatory that in sepsis, to some extent, oxygen delivery and oxygen utilization is dependent on oxygen delivery. But at a certain stage, they lose the alignment, and oxygen consumption can be really independent of oxygen delivery in an extraction in certain very severe septic cases. And that's something we really need to figure out and try to avoid if possible. So many clinicians, including people who did the study, wanted to look at what oxygen target should we really look at, should we target in children. So they looked at about 160 patients, and they identified two groups where one was given 28% oxygen, one was given 35% FiO2, and they fell nicely into two groups where they realized doing a clinical trial targeting oxygen saturation at the lower end IE94 and at the higher end IE95 is feasible. Okay, so they went ahead and did this, and lo and behold, this was their protocol. I'm not entirely sure if they have published this, but I hope they will publish this now that the trial is almost certainly over. I think this is from 22, and it will probably have significant implications on our practice. But it's very interesting to see that they actually targeted a saturation of 88 to 92%, and they felt a liberal target was something more than 94%. So they, in sick patients, if they're ventilated, they adjusted their ventilation settings to achieve a target saturation of 88 to 92. I think doing this itself will change practice within units who have participated in this trial, irrespective of the outcomes of this trial. Okay, because I think it is safe, perfectly safe, and I'm sure my colleagues, John Papachan or Samir or Rachel, will vouch for this fact. So this is a completely randomized trial. This is multi-center, and this comes from Mark Peters at GOS. I failed to look up whether they're published or not, but that's one bit of homework you can do as well. So thinking about pain relief, I think it's, I'm not going to delve much into the pain relief aspect, but we all know the doses of paracetamol, except that below 10 kgs, we need to use 10 milligram per kg if it's an IV dose. And I think NSAID use are never used as much. I've never seen NSAIDs being, non-steroidals being used in the post-op period as much I've seen in the last 3 or 4 years, mainly because we used to rely fairly heavily on opioids, either morphine or fentanyl. But the important thing is to remember to optimize opportunities for bundling care. For example, if you have a patient with, say, septic arthritis, if they are often going to OR to have a septic knee or hip or whichever joint is infected, most commonly the knee. And I think that is the time when they're asleep to make sure the surgeons know that clinicians are available in the hospital to put in a PICC line. So this requires liaison with the orthopedic surgeon. And certainly if you are anything like us, managing patients with empyema, I'm sure in the last couple of years. So if a patient is having a procedural sedation, either a GA, either inhalation anesthetic or ketamine, then I think making sure they have adequate access, because what else is going to happen for a patient with empyema who needs a chest drain? Of course, they are going to need a chest drain, but also they're going to need antibiotics. So making sure they have some secure access, either as a PIC line or whatever variant is available locally, I think that's extremely important. I learned this slightly hard way using ketamine in children. For children for procedure, it has a distinct catatonic effect. And if we don't warn parents as to what is going to happen next when somebody has ketamine, some of them go completely berserk as to what's happened to their child in front of their very eyes. In fact, nothing has happened. It's just ketamine having its effect, not a side effect. That's the effect of ketamine, not a side effect. That's almost desired. So when we think about fluids, I think there's a couple of things we need to get our heads around. So when we think of maintenance fluids, definitely the fluid needs to be isotonic. I think when I started working in pediatrics, we are still using hypotonic fluids. Half saline was the norm, 0.18 saline was the norm, and this led to iatrogenic hyponatremia for several patients. So I remember kids with bronchiolitis coming into hospital, we often gave them IV fluids. They had a low sodium to begin with, and the sodium fell down further because we gave them a lot of fluid. We gave them fluid with very little sodium, most probably. And few of these patients had seizures. So that's how myself and many of my colleagues or registrars at the time became very proficient at doing LPs for even for infants. They had come to a hospital with bronchiolitis, but they ended up with hyponatremia. And that was the cause of the seizure, no other infection. So we need to be really careful about what fluid we are going, and do we need to give IV at all? And if you are giving IV, the next question is how frequently should we monitor serum electrolytes in children needing fluids? I think the much better solution to this is to give enteral feed. So I'm a big fan of using NG tubes if needed. They're well tolerated if they're checked to be in the right place. And then we don't really have to worry about doing bloods to check electrolytes and making sure the sodium is okay and so on and so forth. What sort of fluid is this? Anyone has any idea what sort of fluid is this? This is some sort of, I think, bottled water available on the shelf. This is not an IV fluid, so don't worry. Nobody's going to give you any such fluid of this nature to any patient, leave alone a child. But I think important to realize that there are balanced fluids available. A big prospective trial done in the ANZIX part, the New Zealand Australia group. They were looking to see if balanced fluid is better than unbalanced plasma light, I think, compared to saline. There is nothing normal about saline, by the way. It's a totally abnormal fluid, but that's the one we use most commonly, i.e. 0.9 saline. So unfortunately, they didn't find any significant outcome difference between saline and the other group, balanced fluid group. So I think we are no wiser. And that is because fluids per se are a very small part of what we do for our patient. Okay, but there are lots of interesting papers around. We think of sepsis management mainly in terms of fluid boluses, and that may be true. And if you don't know about Catherine Maitland, I think you should. And I think from her publication of the FEAST trial, which was conducted in sub-Saharan Africa, people became aware that actually administering fluid boluses to children can be a risky thing to do. But if we apply those findings to a resource-rich area or a healthcare society, that's not going to work. There are two completely different healthcare situations. So sub-Saharan African medicine is dealing with completely different illnesses, malnourishment, etc. And you cannot apply the same trial results to your practice in a fluid setting, particularly in the West. So there were absolutely no takers in the West to apply. But what that has led to is not fluid liberal policies, but fluid restrictive policies. At least people are thinking as to what harm fluid may cause. But this is a very surprising trial. I think this came from published last year, and they very small numbers, not enough to base your practice on, but all children who had shock, all of them, I think, who got fluid boluses, I think had a bad outcome compared to people who did not get a fluid bolus. Maintenance only fluid therapy resulted in at least a good outcome. And lo and behold, they said that troponin and lactate biomarkers are actually good outcome predictors. There are several studies looking at lactate as an outcome predictor, not only in pediatric shock, but also post-op cardiac surgery. And that's not a new finding at all. But I think, if anything, this study highlights that we should be very careful about applying or generalizing study results to apply in your population. Okay, so if they're not a similar population and you're working in a different environment, then I don't think the same results are applicable. But fluid challenge in critical ill patients, I think if you look at 2 decades over time, so the important thing to realize is in the last 10 years, almost all the studies, this is looking at number of studies, not number of patients. So when they looked at 272 studies and they collected data from 124 studies, it's much more number of patients included in those studies. This is adult ICU data, and Maurizio Ciccone was a I think Intensive Care Society, the European lead, I think over the last couple of years, I think he's given way to somebody else now. But he's a clinician from London, and he and his group here have demonstrated that I think all the studies looked essentially at fluid challenge over 10 to 20 minutes. So that has definitely been a practice change in the last few years. And if you are not aware, I would definitely urge you to think how much fluid is possible to give via a yellow gelco, a blue cannula, and a pink cannula. So all those cannulas, the devices, the sheets, the packing which it comes in, it's clearly written on it the maximum amount of fluid you can give through a yellow cannula, a blue one, and a pink one. And the number increment, the incremental value is quite impressive. If you're not particularly aware of that, I would urge you to have a look at that. I'm sure many of you are already aware. So the restriction of IV fluids in ICU, not in the ER, in patients with septic shock has really become a vogue. And I think people have really tried to limit the harm patients come to by the way of giving excessive fluids. There are numerous parameters one can look at, but what has been shown that the outcome with a restrictive fluid versus a liberal fluid strategy is the same, irrespective of. So I think giving less fluid or de-resuscitating is almost as important as you resuscitate a patient. And this really has become the practice now in most ICUs around the globe. So when we think of sepsis, the one thing that will not escape our mind is that sepsis outcomes haven't really drastically changed in the last 30 to 50 years. Okay, so in this French study, I think, again from, I think published maybe in the last couple of years, yes, 22. So it was a multi-center study, not only one hospital. They looked at a big number of patients who had community onset severe infection. So they have excluded things happening in the hospital. So no VAP, no CLAPSI, no iatrogenic abdominal injury, etc., etc. So they looked at 260 children. So the mortality has stayed about the same, 10%, up to 20%, I would say, because another 10% died, but another 10% had severe sequelae at ICU discharge. And I think that the implication of that severe sequelae is a huge burden it places not only on the parents and the child, but also the community as a whole. So I think they looked, and only the French can say something like this. You know, the quality of care was certainly suboptimal in 35% cases. In 35% of the patients they looked at, of the total 260, they said the quality of care was certainly suboptimal, and they can document this in a paper because they have a willingness to improve. I think if we want to improve a system, first we have to measure what's the baseline data and to analyze what is optimal and what is not. And this can be part of a simple audit, or it can be part of a research protocol. So I think if you're working in a healthcare environment where research probably is not very high up on the agenda, certainly documenting care episodes via a formal or informal audit may be something to begin with. So if they are younger, i.e. less than 5 years, or if they have a diagnosis of sepsis with no source, or meningitis, I think they're less likely to get good care. And of course, we know that if you go to a pediatric hospital versus you go to a primary care physician, the care you get is probably very different. But practice variation occurs even within Europe. Okay, so even within places as close as I don't know, St. Mary's in London versus the hospital in Vienna or Amsterdam. So look at the number of. So this is a ER observational study. This is looking at all the patients coming to their hospital. So look at the number of patients. So huge variation between 10,000 to 53,000. I think this one is in Fernando is in Lisbon or Portugal even. And look at the number of patients they admit to their ICU. So 0.3 to 2.2. So this reflects part of the urban presence of hospitals like Erasmus. If you're looking in a high density population and you're the only hospital, a pediatric hospital in that locality, you're going to let at all the sick patients as well. Whereas somewhere in Austria, they didn't admit a single patient to their ICU. Now, I don't know what that tells about their population, probably good things, but this is something you need to be aware of in your locality or in your region. What are the practice variations? So I think just being aware of this will enable you to think about how many beds need to be in your hospital, how many ICU beds are needed, etc., etc. Probably not at this stage in your career, but I'm sure there are many clinicians on board amongst the 50, 60 participants who are still around to think about how many ICU beds you will need within your hospital. So this is, again, a very, very common medication we use. How often do we give it, and whether we realize that we're actually giving more salbutamol to some kids than we are giving to adults. And this is one area where I happen to have had done some work myself with my colleague Neil. And I think when we set about a regional guideline, we realized that we're actually influencing care. And I think if you looked at the current numbers, almost 100% of patients with asthma should get IV magnesium. I don't know the data as of now, but I'm pretty sure in our unit, certainly, we are giving almost all our patients, even the infants who come in with these, anecdotally, many of them have benefited with magnesium. And IV salbutamol I've not used in the last 4 or 5 years, and I'm increasingly led to believe that it's not essential part of equipment or essential medication, mainly because we haven't really needed it. So the big problem was significant lactic acidemia, and we've seen patients as lactates as high as 10 when using IV salbutamol, and yes, they avoid intubation, but I think we can achieve the same outcomes with using IV magnesium compared to salbutamol. And this has been documented by several researchers across. This is not geography specific, and I think we understand very clearly why the beta adrenergic agonists drive lactic acidosis. So this has nothing to do with perfusion. This is purely a metabolic phenomena, but there is no easy way to know the acidosis is caused, the lactate going up is caused actually by the salbutamol, and all you need to do is withdraw the salbutamol and lactate will go down. There are lots and lots of articles on this. I'm sure you know it all. Okay. The other common problem was tremor. Okay, so many children not only get lactic acidosis, but many of them will develop tremor in the IV salbutamol group when compared to IV aminophylline group. And the third common side effect with salbutamol, of course, is hypokalemia, augmented by the fact that many of these children are vomiting. So salbutamol induced vomiting also is extremely common. It makes you feel terrible as in absolutely terrible, IV salbutamol particularly. So think about, do we need it and how much are we giving? So my colleagues again in the same team realized that patients about 10 kg are getting more salbutamol than you would give an adult. So adults get maximum of 20 microgram per minute IV, but infusion for a 15 kilo child would reach twice or even thrice that amount. So that's an anomaly, and this is as per BTS guidance. This is not a wrong prescription or wrong medication error. This is just what the BTS guidance said at the time. This was, I think, 2013, 14 or something around that time. Okay, so I know we are running, coming to a close, but this is another very important area to think about. Okay, is antimicrobial resistance a problem? And I think nobody is better qualified. I invited a speaker to tell us a little bit about this. I'm not going to play the full video, so bear with me. This is available on the BBC website. And I think I'm just going to play maybe 2 or 3 minutes of this to see if it will drive home the message.
Our entire medical system really relies on antibiotics.
This would be the biggest health crisis that we've experienced this century.
We don't hear about it, but it's already here.
Nobody is safe until we're all safe. War. More people died of infections and wounds than died actually on the battlefield.
Here, man has lost his heaviest artillery.
So I think it's well worth a watch. And I think the bottom line for me, from having seen that, having seen patients who come to us with an infection, is that I think if we carry on at the same rate, in about 50 years, we'll effectively wiping off the benefits of advances in surgery, in chemotherapy, treatment of cancer, and many transplantation certainly would have no meaning, because I think it would, having resistant organisms to the extent that we are seeing now, and the prevalence is going up every year. So predicted about 50 million deaths by 2050 from resistant organisms. Okay, that itself is not a scary number. It's probably accurate. And I think we've seen more and more patients with increasing bugs. So what can we do? I think as clinicians, we don't need to feel pressured, okay, to prescribe antibiotics. So if it's an infective illness, yes, prescribe antibiotic. If it's an infection If it's clear that the infection is not caused by not causing the symptoms, i.e., they are commensal, they are in a non-sterile area, not in the blood. So isolating Staph aureus or H. influenza or strep pneumoniae from a ET aspirate doesn't mean that it's causing the infection. It may just be there, but it's not causing infection. So think about when you want to prescribe broad spectrum antibiotics. Of course, you have a sick patient with shock. You have no option at this point, but de-escalate to something narrow spectrum when the sensitivities are available. And if there isn't an antimicrobial stewardship program in your hospital, if there is one, please participate in one in your institute. And if there isn't one, think about how you can get an area-wide participation going on in your own locality. And this is something very simple. And I think I would encourage our colleagues or nurses, parents to think about when they should be washing our hands. Okay, something as simple as washing hands can achieve brilliant outcomes in preventing nosocomial infection, particularly in nurseries where the bed allocation area is not huge. There is cross contamination available. You should really think about minimizing the spread of infections. Okay, so I think we want to think about the inadvertent side effects of what we do, including things as simple as fluid boluses, de-escalating the volumes when we give enteral feeds as much as possible. You de-escalate salbutamol, you de-escalate antibiotics, and I think this requires a lot of collaboration with your colleagues. And of course, you are going to wash your hands. Okay. Okay, so Dr. Ahmed mentioned at the beginning, so learning from adverse events. Okay, so I don't know if you're familiar with learning from excellence. So most of what we learn is what we want to be like someone else. We like Dr. X, Dr. Y. What do we like about them? They are very good at maybe doing a procedure. They are very good at teaching a particular skill. So that's how we learn. So we are also learning from excellence. How do we define excellence? When we realize, when we like somebody doing a particular action and we want to emulate that, that's how we learn. So most 90% of our learning comes from excellence, though we don't necessarily think of it that way. And we don't certainly celebrate it, we don't document it. Okay, nobody writes an excellent report. I don't think in our organizations, maybe they do in your organization, but in my organization, there's very little learning from excellence happening. Okay, or at least documentation of learning from excellence. But many organizations think they learn from adverse events. There's only about 5 to 10% of what we learn happens from adverse events. And thankfully, I have yet another teenager. So, okay, I'll let you have a read of that. And then we will proceed a bit further. You don't know this at this stage, but this patient presented to one of the small islands of the coast of England. Not England itself is island. I know the UK is island, but this patient was on a small island. There are several islands around the UK. This patient presented to one of them. And this is his X-ray. So you will say, okay, this is X-ray, give me some numbers, give me some data, because the X-ray doesn't tell us how sick or not the patient is. So what do we think? How many of you feel this kid is very sick, a little bit sick, or not really sick? Okay. I think it's not difficult to realize this kid is really very sick. Okay. And I don't actually believe that diastolic BP. In most likelihood, I don't think that's accurate. Okay. His lactate is already high, is fairly acidotic, and his CRP is through the roof. Okay, so what has caused this infection? Yeah. So thankfully, he's had a very good team around him. They've given him fluid bolus. They've started some epinephrine infusion. He's tubed. Even though his saturations are absolutely normal, thankfully they have tubed him. And no surprise that actually he had severe hypotension requiring epinephrine post-induction, but thankfully it didn't arrest. And with a little bit of fluid, his CVP has gone up to 17, his lactate has gone up, he's passing urine, thankfully. His hands and feet are cold, he's sedated on that adult ICU with fentanyl and propofol, with what I think are fairly generous doses of epinephrine and norepinephrine. And the only way you can get him to mainland, i.e. to UK, is in a plane. Okay, is he too sick to transfer? And what should we do next is the question facing our team. So the local team now are really unkeen for this patient to go. Okay, so they say, why do you want to take him? What can we not do for him in our ICU? And I think the answer to that has to be very clear if you are transferring a patient from one place to another place. What is it that the patient needs doing? So we did undertake the transfer mainly because we thought we could give him oscillation, we could give him a CVVH, in renal replacement, and also ECMO. Okay, and I think we are very lucky because we have got him to come and talk to us.
In the run-up to my illness, I was studying hard to prepare for my GCSE exams. I was set to take French, engineering, geography and history. My parents arranged for an osteopath to come and visit me at home. He worked on my back, but unfortunately there was little improvement that night and at Nobles Hospital on the Isle of Man, but although urine and blood samples were taken, I was sent home with some strong painkillers. My GP took one look at me and an unusual and exciting or daring experience. Plans were in place to take me to Alderhay Children's Hospital, where they hoped the medical professionals there would have more idea of what to do with me. The task of getting me to Alderhay was given to the North West and North Wales Paediatric Transport Service. I was taken by air ambulance from Nobles Hospital to Alderhay. On arrival at Alderhay, I was rushed straight into the intensive care unit, where numerous teams of medical professionals awaited me.
So I think this is from YouTube, and if you do want to have a look at it, I will definitely be willing to share that with you. So I think in this instance, we had a small window of opportunity to transfer with clear identification of risk. We knew that we could do ECMO for this patient if needed. Indeed, he needed it. And he went through a lot of complications, but his renal impairment recovered. And I think this is him talking maybe a year after or 18 months after he went through all that. But of course, I think he had a decent neuro outcome. And I think you'll agree with me when I say that. So I think this is something I would encourage you to think about. You may not be working in a center where you're currently having access to ECMO, perhaps for septic shock. And I think it's important to realize why these patients complain of severe muscle pain in septic shock. Okay, it is a classic description in the big muscle groups, particularly in the thighs or back pain. We don't see so much of meningococcal disease now with the vaccination that's available. And certainly staph sepsis is not very common, but when you see it in a patient like this, you will not forget it. Okay. So I think if you do see something unusual, ask or phone a colleague. Okay, they might have seen something that resembles your patient, and do not fall into the trap of confirmation bias. So it is extremely difficult when you start your new job to feel able to challenge your colleagues. Okay, you're not challenging your colleague, you're behaving in the best interest of your patient. Okay, is it really bronchiolitis? So if you see a patient out of the blue when you don't expect it, so we know bronchiolitis has a seasonal variation. So in August, a patient presenting with apnea is very unlikely to be bronchiolitis. Think of other differential diagnosis. and most certainly invest time in history and examination before we go on to some. This young man had an MRI of his spine the day he came to hospital with back pain, but nobody thought he might be having staph sepsis. Nobody thought of doing an X-ray. Nobody thought of doing a blood gas for him. So as simple as that. And I don't think anybody actually examined him. So many things can be avoided. Falling into a trap is very easy. Oops. Okay. So this is. So if anybody hasn't dealt with a difficult pediatric airway, then I would like to think it's just a matter of time. If you spend enough hours or days or years in ICU, you will come across these tricky patients. And I think this young man was managed very well with his team. I think they use ketamine as a sole agent, and you can see the toothbrush very close to his internal carotid artery. Luckily, he had a good outcome. Okay, so there are scary things lurking in the corner if you are willing to work in ICU. There may be lots of failures, but eventually, if you persist, if you work together as a team, more than likely you will have some success. And this is my son Adi with a box of chocolates for all of you. So if you are kind enough, please go to slido.com because there is last, hang on, I don't know. Okay, so let's see if there is another poll. Okay, so if you are able to do your last poll, then I am going to stop sharing and we can, oh no, we can continue to share, but we can look at the chat, and if there are questions and answers, I would be very happy to look at those now. Oh, wow. Okay. So Dr. Amir has given us the link for what the world would be without antibiotics. I can't see any questions here, but yeah. Okay. So if you think it's okay, go ahead. Give me, oh, the last hour. Okay. If you learned something new, that's fine. You can click more than one, by the way. This is not a single click answer. You can click 1, 2, 3, 4, as many as you like. And yeah. And be frank, there's no need to say things are good when they're not good. I think if we provide feedback, then I think there's every possibility that we can do something different next time. If you thought the hour was well spent, your colleagues might invite me again. If you thought the colleague it is a waste of time, then they won't invite me again. Simple as that. So I will stop sharing. Okay. Any thoughts, Dr. Ahmed?
Okay, thank you, Mr. Rajesh, for the very interesting cases. And we have now many participants. If they have any question, they can type just in the Q&A dialog box, or even just if they want to speak, we can just raise hand and I will unmute them to ask. Okay, no questions, either a very, very good sign or a very, very bad sign. But anyway, there is, okay. Dr. Hara is taking salbutamol can increase heart rate.
Definitely, yes.
Is a statement or a question, but I think yes. Dr. Mona raised the hand.
I think when you're treating, managing a difficult asthmatic, one of the things I tend to look at is the heart rate trend. So if the patient is getting better, you'll see the heart rate actually coming down over a period of time, not immediately with salbutamol. Of course, in the first instance, the salbutamol nebulization will, it's a beta agonist, so the heart rate will go up. But with achieving the bronchodilation that we want, the patient gets symptomatic benefit and the heart rate actually starts to come down.
Okay, Dr. Mona, she is raising a hand. Dr. Mona, you can speak now.
Yes, I want to thank Dr. Rajesh very much for his lecture. And I wanted to ask him when he said that now IV salbutamol is not much as used or is not as much beneficial as the IV magnesium sulfate. I have one question. Do you use this in neonates even if in bronchiolitis? Because we usually use it without an evidence base for that. And we see good results.
With good result, you're saying?
For the IV magnesium sulfate instead of the IV salbutamol. We don't use the IV salbutamol very much, but we actually use the IV magnesium sulfate even with the neonates who have sometimes bronchiolitis, and sometimes we get good results for that.
Our experience is the same. I don't think, well, there has been a magnetic trial looking at inhaled magnesium sulfate for asthmatics, but not for bronchiolitis. For infants, I think less than 6 months, there is anecdotal experience that magnesium works, and salbutamol, well, we know salbutamol won't work in bronchiolitis because they don't have asthma. So there are very, very few children who might benefit from salbutamol, but if the first one doesn't work, there's no point repeating it. But yes, magnesium does work. I agree with you. Magnesium definitely has a role, but I'm not come across many studies or certainly big RCTs looking at magnesium, IV magnesium in bronchiolitis. So I think we should use it, but we need to use it carefully.
So you mean that in your experience, you also use it as an IV, sometimes as inhalation as well?
No, we are not using inhalation magnesium, not available in my hospital. And in fact, the magnetic trial did not support or recommend its use. There are no significant benefit with inhaled magnesium. IV magnesium, yes, we have anecdotal experience and it works.
Even without any evidence based for neonates?
When you say neonates, are you thinking less than 4 weeks?
Yes.
Bronchiolitis in less than 4 week neonates, we don't really see that much, number one. Number two, in our current hospital, less than 28, less than 30 days goes to NICU. And but I don't think they are using magnesium at all in that age group, less than 30 days.
If he's 30 days or maybe 2 months, you use it. If he's not
2 months or 3 months, I think we have used anecdotally, but I'm not aware of any guideline or guidance or study looking at IV magnesium for this group of patients. Acute bronchiolitis less than 6 months, IV magnesium, I'll have to look it up.
Okay.
Okay, Dr. Rajesh, we have Dr. Hala asked about the tachycardia induced by the salbutamol. I think she asking about a patient here, the heart rate reached 230.
I think heart rates about 200 are extremely uncommon with only salbutamol. It is likely to be something like a SVT. We have to be very careful with heart rates in that age, in that range, about 200. I would certainly document ECG if the heart rate's that high, and make sure that it is not a SVT. It could be a drug-induced tachycardia, and the only way we'll ever find out is we withdraw salbutamol from the treatment algorithm. I've certainly seen tachycardias with theophylline toxicity or aminophylline toxicity. We had a couple of patients when we used aminophylline in those ranges that were beyond what is prescribed, and they ended up with significant tachycardia.
Okay, as salbutamol is a very commonly prescribed, we expecting too many questions about salbutamol.
Yeah,
We have
yeah.
another question about salbutamol. Dr. Muhammad Arafa is just is thanking for the lecture and want to confirm you are not using Ventolin infusion for the last 4 years.
Yeah, yeah.
Are you
Yeah.
right?
Yeah.
This I can tell yes. And if used, what is the maximum dose? 1 to 5 mic, or we shouldn't exceed 20 mic per minute?
I think we should not give children more medication than we give adults. That is, I think that is the basic tenet or basic principle of practicing medicine, isn't it? So yes, we want to give microgram per kg, but when we reach 10 kg, 2 microgram per kg is 20 microgram per minute. So if you're giving anything above that, even if the BTS guidance suggests, you're more likely to encounter adverse effects of the medication. And hence, I think we should be very careful when we are doing that.
Okay, another doctor, he is asking about metabolic acidosis is associated with beta agonist and not aminophylline.
No, I'm not seen with aminophylline. We're not using aminophylline for asthma. Recently, we've not had to, but certainly with aminophylline, I've not experienced the same degree of acidosis. With salbutamol, yes, the much more prone to causing type B lactic acidosis.
Okay, and what is the mechanism of that? Dr. Sab is asking.
The mechanism is we'll have to go back to the Krebs cycle, and all that happens is there is more lactate generated. There is a very nice paper on this. I can send you that paper from Kathleen Meert, I think. And we can even do a blood test to look at the lactate pyruvate ratio. So if it is less than 2, then it is beta 2, type 2 lactic acidosis. But it is not available in any lab in the world, I think. This is only for academic research purposes. So that is the mechanism. I'm not very familiar with the exact Krebs cycle at this minute, but if you want, I can send you the paper.
No one is familiar with Krebs cycle. As you know, just it starts after the glycolysis ends. Okay. I will back to the questions just in order, because one of our doctors is asking about hyponatremia, post-gastroenteritis, how to manage. I know it's a little long talk, but just a few spots will be good.
I think, so managing gastroenteritis, if at all possible, use an enteral route to correct your hydration. If the patient is not in shock, put in orogastric tube or a nasogastric tube, use WHO ORS solution to give fluids. Okay, if that is not possible and you have a visitor, you have a colleague, one of your girls is with you, Dr. Ahmed, I think. Who is next to you?
Sorry?
Family.
Oh, yes, Layla and Noreen, my daughters.
Very nice, very nice. They started learning at an early age, huh?
Yes.
So they're interested in the management of hyponatremia. That's very good. Anyway, so I think enteral hydration is much, much safer. And if you already got hyponatremia, then I think if it's rapidly falling down or if it has fallen down, I think hypertonic saline is definitely the way to go. Certainly if a patient has any neurologic complications or before the patient has neurologic complications, 3 to 5 ml per kg of hypertonic saline, if you have IV access, is probably going to be safe.
Okay, this is the one. The other question, how many times in nebulization salbutamol for asthmatic patient per day? And those, and when prescribed systematically, how many times also, and those?
So I think 3 back-to-back nebulizations is well accepted. If the patient is not having any benefit, you need to think of other therapies, not just salbutamol. So using the full armamentarium of IV magnesium, nebulized Atrovent, Pulmicort, steroids, IV steroids, IV magnesium, and using high flow oxygen or CPAP, and people might not believe this, but there have been a couple of times when we intubated patients and had to use high frequency oscillation for patients with severe asthma. Even one patient I remember, we were thinking of referral for ECMO. And that may be possible, that may be needed, but in response to your question, what is the maximum dose of nebulized salbutamol? I think once you get side effects, I think you reach the toxic level. There's no point in giving more salbutamol. It's not going to do anything further. So if you got tachycardia, if you got hypokalemia that you are not able to get across, and if you got lactic acidosis, then I think that is the time to stop giving more salbutamol to your patient.
Okay, another questions. Can we use aminophylline in neonates safely? And what is the dose and the maximum dose in pediatric based on body weight so that not exceed adult dose?
Aminophylline in neonates, it can be used, but I just follow the BNF or the guideline. I think BTS says 5 mg per kg loading if they're not on any aminophylline. And I think the maximum adult dose is reached when the patient reaches 40 kg. So if the patient is beyond 40 kilos, I would not use any more than what we give adults, I think. But that is based for most drugs, not just salbutamol or aminophylline. There are many drugs which we use, particularly things like midazolam, or that is the other drug we often end up giving more to older patients, teenage children, than adults, and that's never a good thing.
Okay, and another question is here, asthma. What you prefer, using magnesium sulfate as boluses, or we can use it as infusion?
We tend to use it mainly as boluses. I've not used it as an infusion. Have you, Dr. Ahmed?
Personally, I don't use, but there are some units, but it's based on small trials. They're even trying to reach some serum level of magnesium to 3. So they are targeting a therapeutic level. If we can say it as therapeutic level, they are using an infusion and upgrading the dose to reach 3. But it's not supported with very large number of patients.
Oh, yeah.
Very limited numbers. But
I think I forgot to mention that. So when using magnesium, either in asthma or for treating of ventricular tachycardia post-cardiac surgery, we don't really think about the magnesium level. It's a fairly safe medication to use, and even if you don't have access to magnesium, you can use IV magnesium at least 3 doses safely, as far as you give it over a period of time. Magnesium is never a push. It can cause hypotension and vasodilatation, so give it over 20 to 30 minutes. So it's a slow infusion, even though we say a bolus. It's an infusion over 20 to 30 minutes. Yeah.
If they are doing the serum level, they are targeting the supraphysiological level of 3, not 2. That's sometimes happens. Our question after that, what are the fluids you recommend using now to avoid saline, knowing that we use now glucose saline 1:1? If we have to use?
Well, I think there are a lot of, so I think if we have to use fluids, i.e. the gut is no longer working or there is contraindication to using feeding, then I think there are balanced fluids available. But I think there is no real strong data to say either from RCTs, or there is a signal towards benefit from balanced fluids. But as far as you don't use isotonic fluids, you're probably going to be okay. But really try to use the enteral route in patients where there is no contraindication.
Okay, so the glucose saline 1:1, glucose 1:1, it will give us half normal saline, 2.5% of glucose.
Yeah, that's very low. That's very hypotonic.
Yes. So just to Dr. Mano, what the ideal fluid now is towards the higher sodium. So not glucose saline 1:1, glucose saline 1:1. Target the last sodium will be like a normal saline. not than half normal, which is very low sodium. Question after that. How frequent should we test for electrolytes in admitted patients? I think it's a very difficult question because many patients.
I think the more important, I think the more important question should be why can we not feed the patient? Why can we not use the enteral route? I think that should be a more important question in our heads. But if really the patient is NPO either for surgery or whatever reason, then I think in every 24-hour period, we should have some idea either via gas or via the lab, formal labs, we should check electrolytes at least every 24 hours.
Okay. Role of anatropes versus vasopressors in acute myocarditis, which we go for first?
I think so. Every myocarditis patient will behave perhaps differently. Okay, so it almost entirely depends on which healthcare environment you're working in. So at the ELSO conference last year, they presented a case managed at a children's hospital in Boston who had come with very low cardiac output secondary to acute myocarditis, and the patient 18 months old went straight on to have a LVAD. Okay, so he did not go to ECMO at all. You know, he did not go through vasopressors, inotropes, any of this nonsense. So they realized his cardiac output and cardiac function is so bad, they put a LVAD for the patient. Okay, and I think it may make sense, but I don't think you're going to get a big trial to address this question. So use what is most familiar to your unit or your organization and what you feel most comfortable with. So in myocarditis, often the problem is they're often vasoconstricted, but they can be, and I think all of these agents are arrhythmogenic. Okay, so even milrinone is arrhythmogenic. So though it's a vasodilator. So I think you have to use a combination usually of norepi or vasopressin with milrinone to achieve a reasonable cardiac output. But I think cardiac output monitoring and certainly echo is going to help you answer this question. So get help with your cardiology colleagues. They should be on board when you're managing patients with acute myocarditis. You should not be alone in ICU when managing this patient.
Okay, but if he is alone, you recommend a combination of milrinone and one of alpha agonist like vasopressin or
yes, yeah.
Okay.
But why would anybody be alone when they are managing acute myocarditis? You know, that's not a good scenario. That's not good for the patient. You know,
sometimes it happens. You know.
I know.
Oh, yes.
Not by choice. Yeah.
Yes. I hope I didn't miss any question. I have it down for medical doses. Please, what's the mechanism of severe asthma? Okay. I think now we are done with all questions. Thank you for your time, Dr. Rajesh.
Thank you very much.
Okay,
Thank you.
I hope all enjoyed our presentation today. Any questions just before closing?
Oh, please put in your Slido remarks if you have. Just choose 1, 2, 3, or how many ever you think are applicable.
Okay. Okay, I think we are done today.
Thank you.
Thank you. Thank you. Thank you.
Thank you. Bye-bye.
Okay, goodbye. دكتور أمير خلاص كده إن شاء الله.
شكرا جزيلا.
تمام.
Thanks, dear bro.
تمام.
Thank you, Dr. Rajesh. Thanks, Dr. Ahmed, for this practical informations and practical knowledge. احنا متشكرين ليك دكتور احمد على تعبك، ومتشكرين حضورك وان انت وافقت ان انت تكون مودريتور للويبينار الجميل ده. احنا كلنا استفدنا. الحضور بسم الله ما شاء الله، الحضور مش مصري خالص كمان، لا ده عندنا حضور من سوريا ومن اليمن ومن السعوديه ومن ليبيا ومن العراق ومن السعوديه. احنا عندنا الداتا فالحمد لله. ده اللي بنعمله، ان احنا بنقدم معلومه براكتيكال، بناخد خبرات من جميع الدول. شكرا ليك يا دكتور احمد، وشكرا لحضراتكم، وشكرا للحضور. والمحاضره مسجله وكانت لايف على الجروب، وهتبقى موجوده لحضراتكم. الناس اللي هي لسه شغاله في عيادتها، الناس اللي مش موجوده، تقدر ان شاء الله تتابع المحاضره. شكرا لحضراتكم جميعا، وشكرا لوجودكم الكريم.
هو تبعت يا دكتور احصائيات الدول. دكتور رجيش كان عايز يعرف يعني باك جراوند عن الدول اللي هي حضرت يعني.
دكتور محمد هلال هيجمع الاحصائيات بتاع الدول، خلاص، وهنبعتها لحضراتكم ان شاء الله. نبعتها لدكتور رجيش على الجروب التنسيقي ما بيننا ان شاء الله.
تمام. شكرا جزيلا.
شكرا لحضراتكم، وشكرا لوجودكم معانا، وليله طيبه من ليالي رمضان. كل سنه وحضراتكم طيبين وروضه الايام. ما ننساش ان احنا عندنا بكره دكتور انس الشومي من دوله اليمن الشقيق، معانا دكتوره عايده حيدره، هي المودريتور بكره ان شاء الله. هنتكلم على اندوكراينولوجي، هنتكلم على ادرينال انسفشنسي. دكتور انس في المجمع او في الملك فهد، جامعه الملك فهد او مجمع الطب الملك فهد، المدينه الطبيه. ان شاء الله يكون معنا بكره باذن الله الساعه 9:30. هنحاول نعلن باذن الله لحضراتكم عشان نفكركم، ونبقى موجودين لايف بكره باذن الله مع حضراتكم، تستفيدوا ونستفيد مع حضراتكم باذن الله. شكرا لكم، وكل سنه وحضراتكم طيبين. السلام عليكم ورحمه الله وبركاته.